Today's ECG space. You tell me about it, coffee.
Okay.
You.
I didn't expect that. Okay. This is a sinus rhythm, rate of about 60, or a little over 60. Axis is borderline left. It's the QRS is predominantly negative in AVF. And there are also Q waves in V3 and AVF. Looking at the in lead V1 and V2, there's the J point looks a bit humped. It looks a bit humped, similar to what is described as a cove ST segment. That's found in V1 and V2. But the T waves, I think, are okay. So my impression is that the inferior Q waves could be suggestive of some underlying myocardial disease, possibly and it's fractionated as well, the QRS. So maybe an old inferior wall infarct or something. But with the J point in V1 and V2, I'd be concerned about, given the history, whatever the history is, I'd be concerned about Brugada syndrome or some other repolarization abnormality. Thank you.
Also agreed V and V two way. And also V1, V2 look like V2 looks like experiment. And also Brugada syndrome type 2 baby.
Type 2 or type 1?
Type 2 is not like because V1 is not like shock. So,
Okay. Any other comments on that? But the thing is, Taiwan or type 2? Taiwan. Yeah, I guess it's Taiwan. It's called Taiwan. You meant that there's some complexity of ST segment? I think it's Taiwan. Yeah, it's shock. V1, not V2. Brugada time is determined by V1 towards more forward. It's Taiwan. Okay. So
Yes, I think we can find them because we want to talk better. We want to do the show as we more than two to we don't show off better. Come down better. So I think it is to go out. I think.
okay, and so Brugada, that's it.
Yeah.
How do you think the two-way being leads 3 and ABS? It is unusual with Brugada. Okay, we have newcomer, Tatsugi.
the type should be. I agree with. I agree with that.
It's Mongolian language. Oh, okay.
Yes.
Okay, Junyoung, please finalize your thoughts.
I'm not really the fan of the type 1 it's in really very looks like two-way, but in reading 3 there is a small R-way. So I'm not sure about it, but looks like a synergy two-way.
Yeah, think the Q-wave in AVF is very unusual, like a pacemaker hump, right? If you look at the lead three very carefully, there's very small R wave before Q like negative deflection. I'm not sure. How do you think, the joke?
I think that cube like wave three and maybe like to be as was finding like there.
So yeah. Anyway, you mean we need to be very careful to
Yeah.
interpret this QA. Potential there's associated old microinfarction. Is there any reports the relationship between Brugada syndrome and the imperial MI? Check the ChatGPT. But actually, I never heard about that. But there was all the reports that when the interventional cardiologist do the spasm test utilizing the acetylcholine, Brugada syndrome patient B1, the ST segment elevation exaggerated. Okay, because the Brugada syndrome is associated with parasympathetic nerve activity. And there's a report ST elevation B1 and spontaneous induction of BF. So, but I never heard about the imperial MI, the Brugada syndrome, whether there is an association. Oh, you already read something. Were there? No. Okay. Nothing to do with imperial MI. At least
Dr. Bob,
GPT's opinion.
Dr.
Okay,
Bob, can you hear me?
please go ahead.
Of the patient.
Mhm.
He is a 48
Oh,
years
you're
old
right.
male patient. The chief complaint was cardiovascular symptoms. Advice was done. President is this. The patient suffered cardiac arrest 4 months ago and was resuscitated. While being followed up by local clinic, the patient developed symptoms, dialysis, stress while driving. So he was transferred to a hospital for further testing and treatment. This was the reason when he underwent the cardiac arrest. It was relief arrest. This one was the page of the day when he experienced the symptoms.
Okay, who will start first? New ECG. It was taken in emergency room, right?
At the local clinic.
Local clinic. Oh, they managed the cardiac arrest patient in local clinic? Oh,
It was at Jeju Halla Hospital.
our hospital is not clinic.
Sorry.
It's a big hospital. 한국사님 들어오셨어요?
Yes, I'm here. Can you hear me?
선생님 새해 복 많이 받으십시오. Happy New Year.
Oh, thank you for everybody. Happy New Year.
I'm very glad to hear your voice.
Oh, I'm happy to see the EKGs again. Now, your first ECG that you guys are talking, why you think there's inferior MI? I am confused.
No, nobody told it is important.
Right.
Imperial MI, but the
Yeah.
Dr. Joe told we need to consider this potential associated.
Right, but there is a small R wave in lead 3,
Yeah.
and then T waves are normal. And then AVF, Q wave duration less than 40 milliseconds. So this is no criteria for inferior MI business. Now, I want to point out just one more thing quick. Look at the V3 and V4. Just end of the QRS. There's a second slope down. Can you see that? V4, you can see better. Just before the F segment, small notching downstroke. Can you see that?
Yes.
Yeah. That's normal?
No.
No, that's the another pathognomonic change of Brugada type 1. Okay? Almost mirror image B1. So this patient has a large area of potential abnormality in the outflow tract or infundibulum area. This has been associated during the ablation. You have to ablate wider area. This type of patient. I'm sure you guys are thinking about
Please say again. Wide area of ablation.
wider area the involvement, so therefore your ablation going to be pretty wide. Okay.
Extensive ablation. I see.
Yes.
So what do you think about the bizarre shape of QRS in the lead 3 and ABM?
Well, I think that is basically you can see the next VF arrest resuscitation tracing, but this is basically dispersion of depolarization repolarization phenomenon happening. Even if you look at this tracing here carefully, you have looks like a regular rhythm going on, and then suddenly there's a premature beat. Look at the following bit. What happened with the QRS? Even further, yeah, that one. You see how it prolonged the repolarization occur right there? QRS duration get longer, merging to almost the T wave, and that happening again. Even you have keep going there. There's another one right there. So I think shortening the coupling alters the further depolarization repolarization abnormality in Brugada patient, which it predispose what? BF. So I want you to look at after that abnormal ECG, especially last one, look at the QT interval, how long that get. Very long. So that's further enhance the possibility of Brugada is not just probably depolarization or repolarization abnormality. They involve both phase, I think. And now you can guys go ahead to this ECG. Tell us about this ECG. What do you see? This is a post-resuscitation, I assume. Right?
Yeah.
Okay. Please read it.
First.
This ECG. I think it's sinus tricky because we were seeing before the QRS complex, and also V1, 2, 3. V1 is the RBB pattern, and V1, 2, 3 show as the elevation more than 2 millimeter, and V1 and V2 show the bigger dome shape as the elevation.
We already mentioned about the Brugada pattern. So what is your rhythm diagnosis? Is sinus rhythm or tachycardia? Or
I think it is sinus tachycardia.
sinus tachycardia. Why is it so irregular? So there, please.
I think it's irregular. Irregular complex not preceded by P wave.
So
Like
atrial fibrillation. Okay. And Pugna?
I think though narrow cure tachycardia, not specifically wave, narrow QRS, some PC or BP wave. Just maybe to population. Or APC.
What is your rhythm diagnosis?
Some APC.
APC.
Yeah.
Sinus tachycardia with APC.
Yeah.
So how do you confirm it? Did you see any abnormal P wave? Copy?
The rhythm diagnosis, I think it's an atrial fibrillation. I don't see clear P waves. There are some bumps in the rhythm strip, but I don't think they are P waves. I think it's just a fibrillatory baseline, and it's irregular. So I think it's atrial fibrillation.
Irregular.
Yes,
right?
irregularly
No
irregular.
P wave.
Yes.
And before I forget, Dr. Huang, we have
Yes.
newcomer, Dr.
Yes.
Sugi from
Yes.
Mongolia University.
Mongolia. Hi. I
Please
met in Mongolia.
Hello.
How are you?
Thank
Now,
you. I come here. Happy New Year as well.
Happy New Year. Thank you. Now, when you guys read the ECG, you just presenter just told you patient had a cardiac arrest and the patient was successfully resuscitated in Jeju-do Hala Hospital. So you need to looking that into the context. During the resuscitation, what kind of medication they would give to the patient when you have a BF? ACLS now, guys. What do you push? What kind of drug you push?
They use that epinephrine.
Epinephrine?
Yeah.
Yes. What epinephrine does to the heart? Increase the heart rate?
Increase heart rate, make it more
And then what else? Predispose atrial fibrillation. Okay? So try to read the ECG in context of the patient background, what happened, changes since first and now then. That shows the patient post-resuscitation probably received a bunch of medication, including epinephrine. That may increasing patient's heart rate, along with the cardiovascular distress, respiratory distress that she's having, probably, or whoever might be this patient. Okay? So try to picture patient's clinical status, try to read the ECG. Okay?
Actually, Brugada syndrome is vulnerable to atrial fibrillation because it is channelopathy. And
Yes.
the interesting finding is the curve type, the Brugada type 1, the ST segment was shown in only V1 and the stable sinus rhythm ECG, but now
B2?
it's extending to V2.
Yeah.
If you, can you come back to previous? No, that's what. Yeah, if you see the rhythm strip before, probably after resuscitation, there is the regular coupling interval,
Sinus rhythm, yes.
sinus rhythm, and the
PAC, couplet.
SPC, right?
Yeah.
Okay.
So she's developing non-sustained
It is
AP.
not. It is not the atrial fibrillation, right?
No, it's not.
Mm.
Okay.
Okay. And
All right.
Junior,
Go ahead.
any other comment? You saw?
Nothing more.
Nothing more. Okay, so let's go ahead.
So, this is just actually when he was in our hospital, and it was normal. And TT, after the resuscitation, there was no structure disease or abnormality. And when he was in our hospital, we underwent the CAG, the LAD and ICA looked normal, but we did the pulmonary provocation test, and it was positive. And you can see there is a total occlusion at ICA.
Oh,
And after that, we decided to implant the ICD.
did they check the 12-day ECG during specimen test? No. And no BF at the time.
No.
Yeah.
Yeah.
As I told you that there was a case report during IC coronary spasm test. There was a BF induction in patient with Brugada syndrome because mechanism is safe. Okay, ICD.
And this was the ECG after the ICD implantation.
Why lead BCD looks so ugly? I think that one is the answer. Aguma, why do you think of B3 so ugly? It's patch problem? Only B3?
Just one lead, so it's not. My polarization.
At least the echo was normal in inferior wall motion, right? This was not a absolute QA. That one was right. The B3. Dr. Wang,
Yes, sir.
can you hear me?
I can hear you. Yes.
Yeah, everybody is waiting for your interpretation of this regarding the V3.
Okay. If you look at the chest X-ray of this patient, how the patient looks, skinny guy, long, right?
Yes, yes.
Okay, let's go back to ECG. Now, where the V2, V3 might be, lead-wise? Precordial,
Mm-hmm.
left side, third and fourth intercostal space?
Yes.
Yes. If you look carefully, motion artifact also present V2 first beat. Take a look at the V2 first beat. Yeah. There is also second one, there is. Yes. This is correspond to V3. That's suggestion of what? This is motion artifact.
Motion. Yeah.
Okay. V2, V3 is a highly predisposed to the cardiac contractile motion, mechanical contraction, irritating the patch. That will give you more noise like this. Also, you have to remember, the precordial leads are unipolar leads. Therefore, they are much more subject to noise than the true bipolar 2,3. Okay? So this is important to notice that. And then if you have a question about it, what you do, turn the V3 rhythm stream on it, and then try to listen to heart. I know many of you guys don't listen to heart anymore, but listen to heart, you will see maximum pulse impulse coincide right at the end of a T wave. That's to make a diagnosis of this is artifact. Okay?
So it is because the skin and the chest wall is beating during
Yes,
heart.
EMI, that's correct.
V3 unipolar electrode is very close to the heart position. That's why. So you told us we see the aortic valve closing signal or the motion signal during the VT mapping, intracardiac EGM. Is that the exactly same mechanism?
Yes, exact same mechanism. That's correct.
Yesterday, I had a hard time to differentiate this motion artifact and the real local signal.
Right. So always try to look at the pressure curve if you have arterial line. That will help you. Okay?
Yes. Thank you. Okay, let's go ahead. Oh, it's finished. Okay, so
Now, do you guys do gene testing in this patient?
Not yet.
Not yet. You're planning to?
Just 10 days ago.
Great. Okay.
I'm not sure the genetic test is mandatory for Brugada syndrome suffered from cardiac arrest.
Well, the patient had a coronary spasm, RCA. So I think it would be important to differentiate.
Yeah, but as far as I know, it is the
No, there is not. Yes, true.
2A indication in guidelines.
Right.
If the patient has low QT syndrome, it's absolute indication for genetic test. But in Brugada syndrome, only 18 to 20% suffers from genetic background.
Right.
So if you want to family screening or the risk of Brugada syndrome, it is acceptable to check the genetic test. But if there is no family history at all and the patient doesn't want to get genetic test, it is the class 2 indication.
So how are we going to treat this patient?
Yes. He has a chronic spasm, right?
Yes.
And the Brugada syndrome. How will you?
Because of the cholesterol, I would start the passing.
Beta blocker?
Calcium China.
Calcium channel blocker. Okay. Because you already implanted the ICD, you don't worry about the VF anymore. How will you treat atrial fibrillation? There's so many complicated situations.
Right.
I think as Dr. Huang mentioned, that atrial fibrillation could be the result of epinephrine fat during resuscitation, but it has been known that the Brugada syndrome also vulnerable to associated atrial fibrillation. So you need to monitor whether he suffer from AP again. And I'm
Question,
like
yeah, question, I
explain
think.
why the primary care, the EP physician put the single chamber ICD because he has the atrial fibrillation.
Question have is that is there a role here, Conidine?
If the patient got ICD shock, I would like to start quinidine first rather than the catheter ablation.
Okay. Yeah. So I mean, nobody's discussing ablation, but I'm asking whether quinidine, in case of a coronary spasm, quinidine has any contraindication. I know you guys are going to beta blocker, calcium channel blocker, but then that will not help Brugada.
Then alternative drug might be psilocybin.
Yes. So I think,
It is very weak.
yeah, it is something that you should discuss in your consultation note, that potentially giving some idea about the cardiologist colleagues some how to treat this patient. Okay. Your role is a consultant as well. You're not just doing the procedures. So it is important to make a habit of writing note, clear cut, explaining all the step by step. That's make your beautiful consultation note. Okay.
Yeah.
Okay.
Dr. Wang, I remember the long time ago you taught me the putting the dual chamber ICD could be unnecessary sometimes to save our. Anyway, it is the
Right.
yeah, waste waste of medical cost.
Right.
But in this kind of patient with underlying atrial fibrillation, do you still think the dual chamber ICD is unnecessary?
No, I think dual chamber, issue is that you still have an undiagnosed workup. Second is that if you give a beta blocker, calcium channel blocker because of coronary spasm, this patient may develop bradycardia, which is going to be detrimental for him in Brugada's standpoint view. So I think there's a dual indication should be thought about it. Only downside is that his chest is small, probably the blood vessels are small. If you put a two lead, you might have increased risk of a lead fracture in the future because he's a young man. So those things that you have to think in your consideration, decide what to do with it. I don't think there's a right answer one way or another. I think only a physician can assess his physical exercise capability, what he does for the job, and things like that. If he's a heavy labor person, let's say that he lifts quite often heavy object and things like that, work in a construction, you may not really, have to compromise a little bit. But the other hand, if he's not a very active person and he's 40 plus years old, and I think I would do favor for atrial lead insertion in this patient in case you have to pace the atrium, increase the heart rate a little bit.
What do you think about the sub-Q ICD in this kind of young man?
Now, I would not do sub-Q ICD if there is any suspicion of atrial arrhythmia involvement. Particularly sub-Q ICD only maybe perhaps good for BVI pacing, which it doesn't do very good. Also, when you pace a BVI, your output tended to be reasonably high. Sometimes patients feel that is very uncomfortable. So I really haven't done that many sub-Q ICD in my practice. It looks like elegant, easy to put it in. But if you look at the last 5-year practice of guideline, as well as the actual number of implantations, sub-Q ICD dropped drastically in their market. So I think, as far as I know, any structural heart disease, I don't put any sub-Q ICD, period. In this kind of patient has atrial arrhythmia, so on, could especially need the indication for atrial pacing, probably very unlikely. Yeah. If you want, you can put a subpectoral ICD, this patient, for the comfortable range. But I don't know what I would put a sub-Q ICD.
Okay, thank you very much. Any other comment, Dr. Yu?
Already lost.
Sorry. It came too late. Okay, thank you very much, Dr. Wang and Dr. Shin. And let's move to for you.
Oh, I hope I survive now. I'm just trying to my flood to the house here.
Oh, still? You fixed it?
I'm just finishing final stage. I'm painting now because it's damaged the walls and all the colors, and so we ripped that up and then put a new wall and then painting.
You must become healthier.
I think
Because
that is the
because of
truth
muscle
because
work.
all the lazy weight gain that I had all lost pretty much all now.
오케이, 레코딩 끊고 다시 시작합시다.
So I'm Young Wei from the branch hospital. Today I will present 3 cases. An outflow track PBCNS3 case, a redo evaluation case, and the last one will be brief EGM review.
3 cases.
This is an outflow track PBC NS3 case. This is a 72-year-old man with a direct cardiomyopathy. He previously underwent VT ablation in December 2022 at another hospital, targeting RBOT approval. But he developed recurrent NS3 and was referred to our center for repeat ablation and device therapy. This 12-read ECG show frequent PBC and NS3. The inferior read are predominantly positive, and AVR and AVR are predominantly negative, suggesting an outflow tract origin and precordial transition is at week 5. This ECG was obtained on a different day and showed the same morphology. Chest X-ray shows cardiomegaly. And echocardiography showed a severe global LV hypokinesia with an ejection fraction of 34%. So we proceeded with an electrophysiologic study. In the EPREP, the baseline 12-read ECG again showed a frequent PBC and NS3 consistent with the clinical arrhythmia. We also observed the other PBC morphology, but our primary target was the outflow tract PBC that triggered NS3. This slide shows the initial catheter positions. We first measured the RBOT using H-degree X. At the RBOT septum, we found the early signal, about 23 milliseconds for QRS onset, but the electrogram was small and we suspect the papillary activation. On the RBOT activation map, the earliest area was colored with white and is broad, and the unipolar signal did not show the QS pattern, again suggesting papillary activation rather than the true origin. With this finding, we decided to use a microcatheter to better localize the source and advance it into the great cardiac vein. Through the SL1 sheath and the JR4 catheter. To briefly review the anatomy for fellows, the coronary sinus continued as the great cardiac vein and can bifurcate into the anterior interventricular vein and the communicating vein. Communicating vein is it runs between the LVOT and RVOT. This 2018 published paper introduced the microcatheter-based approach to map the communicating vein for outflow tract ventricular arrhythmia. After placing the microcatheter in the right cardiac vein, we recorded a little more clear and early signal to distal electrodes. We advanced the microcatheter further to engage the communicating vein. At that position, the distal electrode
That's silence.
the distal electrode showed an even more clear and early signal. Next, we performed the retrograde transaortic approach, and this slide shows the LV angiogram in LAO view. We mapped the LVOT and sinus opera serva, and the earliest activation was found at the left coronary cusp. On the 3D map during the PVC, the target was discrete and narrow, with a clear unipolar quest pattern supporting a focal origin. So we positioned the ablation catheter at the site. The site was close to the distal end of the microcatheter. At this site, we recorded an excellent vocal electrogram with all timing. So it's even earlier than the communicating vein signal. Face mapping showed a 96% match with the clinical PVC morphology. We delivered the RF energy at this site, and the PVC disappeared during the ablation. This slide shows the final ablation site. And the orange dot means the P signal. Because the ablation site was close to the left coronary ostium, we performed the post-ablation left coronary angiography, and no stenosis was observed. On the post-ablation 12-lead ECG, there were no PVC. However, the baseline QRS remained wide with an RBBB morphology. And the patient have LV dysfunction, severe LV dysfunction, despite optimal medical therapy. Therefore, we implanted an LVB area pacing CRTD 2 days after the quick ablation. This is the 12-lead stage after CRT implantation. So that concludes case 1.
Okay, any comments and question? Fellows?
On the post-ablation ECG with the RBBB, typically you would expect discordance between the QRS and the T wave. But here it's concordant. I was just wondering about it, whether it signifies anything. Because I would have expected that the T waves would have been negative with the RBB pattern being positive, but here both are positive. So I'm just wondering if it has any significance.
No. Now, what's your question again? Repeat that again. I'm just confused.
My question is, normally with an RBBB, you have the RSR pattern in V1 with a downsloping ST and a T inversion. But
why
here,
you have a three original?
Pardon?
Right bundle. Even the right
Yes.
bundle, you have a R wave is a positive in V1.
Yes.
So therefore, T wave should follow normally.
Okay.
You can see in the V5, V6, there is a biphasic T wave with a S segment elevation.
Yeah.
That I can understand. But your S segment has been normal Look at the V1, V2 S segment is normal. So why you should have a T wave inversion now? You sure about that? What you're saying? I want
No,
you.
I'm asking. What I'm saying is normally in an RBBB, you would
Mm.
have the upright QRS in V1, and then
Yes.
you'd have a downsloping ST segment with a T inversion. But over here, the ST and the T wave don't look like the typical RBB pattern. So I'm asking if this has any significance.
Kofi's question is why T wave is upright in V1.
Yes. When normally with RBB, it is negative in V1.
Probably repolarization pattern is reversed because of underlying RBBB, but this patient has significant structural heart disease, cardiomyopathy. Dr. Wang, do you have any?
This is this basically V1 and the V6. Take a look at it. As the T wave changes, almost mirror image. Can you see that? Because the V1 looks like a going down a little bit, and then T is upright, and V6 S segment is up, and T wave is inverted. Do you see it?
Yeah.
Yes. That because your left ventricle is also diseased, not just right ventricle. But then if you look at your right bundle branch block pattern is only first 40 millisecond, the right RSR pattern. Rest is all upstroke slow is the left ventricle. So I think this patient has a significant further expression of the left ventricle dominant picture rather than right ventricle. Second is that they look at your P wave. Maybe that answer your question. Lead one is not the M-shaped P wave. You see that? Significant left atrial enlargement rather than right. That further indicating that this patient has a dominant left ventricular failure, probably rather than right ventricular failure. I think that's probably what you're trying to, understand, I guess.
Thank you.
So actually, this patient was referred from another hospital after failed VT ablation, but his VT and PVC burden was quite high. How was the proportion of PVC?
I remember about 30%.
Over 30%. So that's why we discussed about after successful VT ablation, the ICD is that mandatory or not, or we can wait for a while. And if we need, we put the ICD, what kind of device is best? As you know, the companion trial sub-analysis shows that underlying RBBB and cardiomyopathy, CRTD may increase mortality rather than reduce mortality. So that's why we consider just a dual chamber ICD or LOT ICD, the CSP plus ICD. So in this kind of case, do you wait for a while to improve the ejection fraction after successful VT ablation, or implant the device together?
The reason is that I think maybe answer is lie on the EKG. Okay, we can understand that the PVC induced cardiomyopathy, but they tended to be typically QRS are fairly normal ventricular activations and normal pattern, not like this wide notch. Look at the V4 downstrokes, so much notching on it. That's usually known to have an indication for the prognostic standpoint of view. So this patient has some markers, especially ECG in the V3, V4. You can look at it, and then also V5, V6 has a deep S wave. I think including S segment changes there, T wave elevation. I would not wait for this patient. Probably maybe patient of higher risk of sudden death, even despite that. So I think you better protect this kind of patient, especially, you had a PVC ablation done from the aortic intercuspid just above, I guess, where the catheter was. And typically, I'm not sure that, unless you have a sustained VTNA with a frequent PVC from that area causes such a severe heart failure. But then EKG markers are too much, confused and complex to indicate that the patient has a significant underlying heart disease. Maybe just PVC is an associated feature of this cardiomyopathy rather than your, PBC
Yes.
cardiomyopathy.
Yeah, so I had similar thoughts. So after reviewing the echocardiogram and cardiac MRI, the chamber size was very big, and also there's a large LG in the cardiac MRI. That's why we decided to LOT ICD in this
Yeah.
patient. And
I mean-
also another question is during with PBC ablation, I mapped everywhere in commissure and the LB summit and everywhere, but the only focal point successful ablation site shows early stage patient. But unfortunately, during ablation, patient screamed because of chest pain.
Mhm.
That's why I checked the coronary angiogram immediately. It is,
Mm.
I think, 1 or 2 millimeter away from the coronary artery ostium. So, in such case, what is the most the safest method to successful ablation, Dr. Wang?
You look at the ablation catheter orientation. Now let's take a look at that for a minute. So fortunately, you're pointing down to the annulus. You're not pointing to the left main.
Mhm.
You can almost imagine this is some sort of a small, imaging there at the coronary cuspid. But my guess is that if you mapped again with this microcatheter placement in the intercuspid below the valve, I wonder it would be the same signal or even better maybe. Have you done that?
Yeah, I mapped that area very long time, but I could not find the better places.
And then the intercuspid space was available or was not able to get in underneath the valve?
Oh, I also mapped make the U-shaped curve and map
Yes.
the cuspid, but I could not see any early stage.
Okay. Yeah, because of typically, this position that you're ablating, I think most of us, we can get the same spot from under the valve because it is a common sharing triangle shape area. But maybe orientation of your catheter pointing straight to the catheter had a better recording. But you notice that your ablation signals are mostly all of them early, but as a far field signal. They're not a near field signal. So that's why I'm asking that question. I think the safest answer, bottom line, safest thing to do is ablate from the below the valve rather than ablate from the cuspid. Now, when you're ablating cuspid, you got to make sure pointing toward to the down to the annulus, not toward the left main. Like, the other day, somebody presented the case and had some issue. Now, in the CS12, your signal that's showing you right now, there's initially CS12 has a very early small notching potential there. Is that an artifact? Yeah, that guy.
I'm not sure that is the artifact. It is
Maybe catheter motion? Because if you go back to your very first slide when you guys mapped early, keep going, yeah. Keep going. There was a signal there.
microcatheter research.
Yeah, so you have his spot. No, right there. You just passed. Go back there. No. Yeah, right there. Hold on. That's 23 millisecond you're recording. That potential. G8667. You see that? That even earlier than you see that. I'm not sure that's the real signal. Okay? So I think that's probably artifact. But the second potential they see end of the cursor maybe is earlier because you don't see that again in other signals. Can you see that? In other consecutive 2-bit, they are not there. The early signal you marked as early. Okay? So in order for you to mark your cursor, is the proper space or not, you got to make sure that your subsequent bit also has the same potentials, and you don't have it. So I'm sure I think I would consider the artifact. Even the EKG changes a little bit around. I wonder that's a huge bit between sinus and the PBC because the initial vector of PBC different. Can you see it? Your QRS complex different. First bit and 2 subsequent bit. Okay? So you should not mark that as your mapping EGM. So your signal here is late. maybe imagination, G14, 15 has a something at the front, I would argue, because they are more consistent. Come back to second beat, yeah, that one right there. And then you have a next beat, you can see even more noisier, right? That one, okay? They might be real. But the first one you marked is, I think, is an artifact. Okay, go to next, please. Keep going.
One,
Yes, sir. Next slide.
you with me?
Yes, I'm with you.
Internet 문제 같은데. Yeah. Okay, please
Okay, go
share
ahead.
your experience. Dr. Yu.
Yeah, there's nothing more comment on, but just, yeah, thank you for such a successful case, and yeah, with all my respect.
Not always successful, but I have experience of accidentally my ablation mapping catheter tip slip into the main coronary artery. And unfortunately, that site was the very earliest point. So at that time, I didn't ablate and gave up the case, but it happens if you carefully map it. Summit and the cost value. Don't burn inside of that.
I wanna point out something for Junior. When you read the circulation paper, 2018, can you show me?
Although most focus can be eliminated by below the valve ablation, but how many cases you need to do above ablation, above the valve?
Many.
That proportion is many.
Number one is, even though it is a little away from the real focus, the catheter contact is very good, and catheter is very stable. And of course, the below valve ablation is safer, but if you look at the report from the pathology, the myocardial sleeve and the valve consequence irritations is very small amount. And the non-coronary cusp, almost no muscular sleeve. Left next is left coronary cusp. Right coronary cusp, lot of muscular sleeve. So usually, when I succeeded the above valve coronary cusp ablation, just a few second ablation, single ablation was good enough, because the PVC coming from the small amount of myocardial sleeve. You don't need to burn too much. But the below ablation, especially summit, sometimes you need hyper long duration.
And I have one more question. In RVOT PVC ablation, if the signal is not very good, I usually go opposite the right way to the LVOT, but in between you mapped the communicating thing. So I think you might have suspected at that time LVOT origin. So where did you go like right away?
The reason why I mapped the communicating vein by microcatheter is, if it is really the communicating focus, I don't hesitate to puncture the femoral artery and transaortic approach. But sometimes it looks I failed the ablate at the RB outflow track, but the yesterday case was exactly the same one. The Junyoung associate participated procedure together. It was RV outflow tract mid-septal area, ablation, eliminate the PVC and come back. So, but the frequency of PVC is very low after RV outflow tract ablation. But I thought it was failed ablation. So that's why I mapped because even though transaortic mapping, if the PVC frequency is very low, we will fail. Unnecessary puncture and unnecessary extra long sheets of materials. So I mapped the microcatheter. It was away from the RBL for the target site. but still we could not eliminate PVC. So eventually I punctured the femoral artery and mapped the aortic cusp and LV outflow tract. As microcatheter shows, it was away from target site. So I did unnecessary the aortic puncture because it takes less than 10 minutes to map it. But if you use the right femoral artery puncture, you need more material, angiogram, and everything. So main reason to use the microcatheter is my case to be more efficient. But it depends on the operator. If you like the blood bleeding, definitely.
Okay.
Right. But the
Can I ask a question? Dr. Wang,
Huang, are you there?
I'm here. Can you hear me?
Probably the internet problem.
Okay.
Okay.
If you do.
Why don't you give a question during Dr. Wang?
Can you hear me now? No.
If you do about ablation, I think maybe coronary angio is more appropriate.
I do the aortograph first.
제 말 들리시나요?
And the location of awesome. Okay. Any other question or comments? Because the Junyoung prepared 3 cases.
황준 선생님, 저는
Okay.
선생님 목소리 잘 들립니다.
If not,
잘 들리는데 거기는 안 들린다 그러는데?
네, 여기가 안
저도
되는
very
거예요.
들리는데
much.
저기는 안
Very
들리시는 것 같습니다.
interesting case, but let's review the yesterday case. It was a failed case.
거기
I have many questions
랍에서 안 들리는 것 같아.
to share with you. Okay, please, second case. Please, the record. Stop recording and record again. 뭐야.
들리시나요?
예, 들립니다. Can you hear me?
네, 저는 선생님 말씀 잘 들립니다.
여기 스피커 문제였던 것 같아요.
You
우리
guys are speaker problem. Okay?
이거 문제. 죄송합니다.
아니 그게 아니고
네.
첫 번째 케이스 그 PVC morphology 보시면은 there's no evidence that's a right ventricular outflow tract.
예.
Look at lead one is a tall artery of RSR. And then your transition is very late, wide. So this already should start thinking that this is a lopsided PVC, not the right side PVC. Or could be an infundibular PVC from right side if this was right, because your transition is late, B4, B5. So I wonder if you mapped it from the right side infundibular area also, would there be any value on your case? That's what I want to say. Okay? That's what I can tell you.
Dr. Wang.
Yes, sir.
We will prepare the the lead one negative RB outflow tract PVC ablation, but failed yesterday actually. And please comments about that when you next week or when you come to Korea.
Okay.
Yeah.
Yes, sir. I'll be happy. Okay.
Yeah. Thank you.
I'm surprised that Dr. Park failed the case. Okay.
I'm honest to people. If it's
Okay.
yeah, even though the PVC burden reduced remarkably, I guess it was failed case.
Okay. Let's go. Case 2.
Yes, case 2.
How many cases to go?
In case 2, this is a redo AFib ablation case for recurrent atrial tachycardia. This is a 77-year-old man with rheumatic heart disease. He underwent percutaneous mitral valvuloplasty in 1991. He had a persistent AFib and previously underwent 2 ablations including the full vein, PBI, and multiple linear region. This year, he developed Fan syndrome and received DDD pacemaker. Recently, atrial tachycardia recurred on ECG, so he was scheduled for ET. The chest X-ray shows the implanted pacemaker and also cardiomegaly. And echocardiography shows stable pneumatic valve and severe but stable disease, and markedly enlarged left atrium and preserved LV systolic function. We proceed with the APS. This slide shows the catheter position after transeptal puncture with an H-degraded catheter placed in the left atrium. At baseline, the rhythm was pacing dependent. We first assessed the pulmonary vein isolation in the RSPB. There were no pulmonary vein potential except the occasional contact artifact. In RIPB, RSPB, RIPB were also isolated. So we infused the isopropanol and performed rank pacing to induce the clinical cardia. The AT was sustained, so we performed activation mapping in the left atrium. The map suggests the focal pattern in the earliest activation inside the LAA. During mapping, the tachycardia cycle length became slightly longer, so we remapped and again identified the earliest LAA site with in this site. It shows the unipolar QS pattern. We performed the left atrial appendage angiography to better define the anatomy. And we positioned the ablation catheter at the presumed earliest site. At this site, within the LAA, we record the early local electrogram. We also observed the fragment potential in this region. And we delivered radiofrequency energy at the LAA target. However, the tachycardia persists with only mild cycle length change. So at that point, we suspected a ligamental muscle relate mechanism. So we moved to this rich region. And we perform ablation at the rich region. And this ablation terminates the tachycardia. So in summary, the earliest cardiac activation occurred inside the LAA. But the successful termination site was posterior and superior to the appendage. This pattern suggests the Marshall-related cardia with the endocardial breakout into the LAA, eliminated by the operating the Marshall-related connection from the endocardial side. This is the end of case 2.
Oh, thank you, Junyoung. Actually, I asked Junyoung to prepare this case because Dr. Huang is a master of ligament Marshall. He reported the role of ligament Marshall in patient with atrial fibrillation first time in JACC. But in this case, we carefully mapped the appendage focus of atrial tachycardia. Did I try the entrainment pacing?
In LA, inside LA.
Inside LA. I remember I did. And it was the perfect micro reentry. So I guess because there was microentry from inside of the left atrial appendage, I tried to burn it first, but after 2 or 3 burn, I cannot terminate tachycardia. So in the left atrial appendage posterior aspects along the ligament marshal, there was no potential, completely no potential. Did you bring the voltage map during sinus rhythm? So even at the timing of a successful termination of atrial tachycardia, there was absolutely no potential. But I empirically burning along the posterior aspects of ligament marshal, and fortunately, tachycardia terminated at the top of the ligament marshal area. So I wonder it was just coincidence or it was ligament marshal related tachycardia. So I brought this, ask Junyoung to bring this case to ask the question to Dr. Huang. Dr. Huang, are you there?
Okay, show me a 12-lead ECG with tachycardia first. You just fly through that EKG. Okay, let's take a look at the ECG. So whenever you guys see regular tachycardia, try to exercise your brain, try to guess where this tachycardia coming from. Okay? So what happened in the V1? First X is a positive and then become negative. Biphasic, right? Positive and negative, right?
Yeah.
P2, what happened? Is it coming down to the P2, V3? They become what? P2, B2, not the lead 2. Yes. They became a little wider R. And V3 become even taller, right? Less negative. So what did I tell you? You're moving anterior towards the little more posterolateral because you're coming down lower and then to the lateral. Okay, they become maximum positive. How about leader 2-3 AVF? Initial isoelectric or negative, right? Initial leader 2, negative and positive. See it? Negative and positive. Lead 1 is almost isoelectric. So where is this tachycardia coming from? It's coming from posterior, sure, because the lead 2-3 AVF is negative initially, and then turn around, become positive. So there's a typical ligament marshal EKG looks like this. Now, question is though, when you record intracardiac, so you had some pacing done at the, as soon as you put the catheter in. Let's go take a look at the intracardiac signal. Okay. This patient had a rheumatic fever, so I guess had a lot of scarring and big atrial enlargement. So your potentials or most of them are far field, the exception of distal CS maybe is a better wedged. Now, one question I might have for you is that if you thought that this patient had possibly ligament marshal involved after you failed atrial appendage mapping ablation, did you think about doing venogram of a venous marshal or something to give you reference or no? Yes or no?
No.
No. So because the patient had a multiple ablation endocardially before, your signals from lateral isthmus, ligament marshal area, may be heavily damaged or altered. So your signal not going to be good. Now, I can tell you why your ablation signal here is not good. You're supposed to be recording directly from inside the appendage. Look at your signal, ablation signal, distal. What do you see? Far field, early far field R, very slow upstroke. Can you see that? Yeah. So what do you think about the signal? You think you're in the right focus? You're not. If you're going to be inside the atrial appendage, you want to see that first signal very sharp and tall, even though scar the atrium. So this tells you your catheter orientation is correct. Distal to proximal, but distal is R, proximal is slightly QS. But they're far field. You're not there yet. You got to map more. Let's assume that you cannot find anything better than that. What would be your next step? Do empirical ablation like Liga Marshall, or would you do epicardial puncture to map this appendage better? What would you think? This is not uncommon to see in atrial appendage tachycardia because atrial appendage has a lot of pectineal muscle. They're going to be tremendous amount of preferential conduction through the pectineal muscle versus thin wall area. Second thing, I think I talked to this before, appendage mapping, because appendage is very mobile structure. I don't care what kind of catheter that you use. Your appendage is going to move along with it. So my question to you, second, how do we avoid that then? You probably should have two catheter inside the appendage. So you can chase one changing another by early sight. That offer you two things. One, second catheter stabilize appendage, less motion, and also as a marker. And then once you find another catheter early site, then you hold the catheter the same spot, then you move a second catheter to the finding early spot around it. That's the only way we're able to find earliest spot reliably in a blade from appendage. My guess is that probably this tachycardia coming from the left atrial appendage posterior wall, which is also very close to Liga Marshall. And I cannot tell you whether this is Liga Marshall case or not, 100% sure. But then I think that's one other way to do appendage mapping and catheter ablation. Either use a two catheter under the appendage angiogram, you did quite well on that, or you do epicardial puncture, one for endocardium, one for epicardium. That would be the, I think, elegant way to do it. Because of appendage, very mobile structure, you move a catheter inside, it's going to follow your catheter. So you never can really have a reliable anatomic site. Okay? Another way to do that would be one other technique that if you can want to use it would be Orion catheter, would be wonderful. You expand Orion much as you can, and because of balloon-shaped catheter, you can map from the ocean very gently and then rotate the catheter slowly, push it toward the apex. That may be one way to do it. But then, even then, I think I have a lot of problem before, so I prefer use a two ablation catheter, double transeptal, or epi-angle. That's comment I have. I don't know whether this is a Liga Marshall case, Dr. Bach, honestly with you. You ablate a lot of linear lesions there previously, anterior line, posterior box, and all that. So I'm sure you probably got rid of Liga Marshall connection, I think. I assume so.
Actually, in this patient, potential focus of tachycardia was inside of appendage.
Yeah, I think so too.
Yeah,
I agree with you.
Yeah, even though the margin of appendage, rich area is thick, and we can ablate there safely, but you mentioned about the electron is not right spot because I didn't want to perforate this old man's appendage.
we understand, but
that's why I ablated the ligament marshal area and pick ablation, but actually there was old scar and cardially.
Yes, I see you have no signal ablation.
No signal. Yeah.
Yeah. So I just surprised that even though you've done good damaging signal there, but then the lesions are formed, but you QS out there after the ablation, but then nothing really happened. So I think next time, please be patient and then try to map the appendage carefully if you can. And then if you think about that this is a truly appendage case, think about the mobility of appendage, precursor conduction, all those issues interplay in the appendage tachycardia. That's why in Oklahoma, when they think it's appendage, they just go epicardial. They don't bother go really do much. Just leave one catheter inside appendage reference and then do epicardial puncture, go and then find the blade.
So if we have enough time to careful map in this kind of case, do you recommend Marshall mapping or epicardial mapping?
I think in case, since this case has an appendage question, I would do the epicardial first. Okay, that would give you a clear answer. But if you had no evidence about appendage, but you think it's a Veno Marshall, then you can do Veno Marshall mapping with the 2 French catheter if you can. Okay.
Okay. Thank you very much. And any question regarding the ligament Marshall appendage origin tachycardia? Okay, Dr. Park.
If you're going to do inside LA ablation at the tip, what is the typical energy and time that might, although cannot be definitely said, but relatively safe, if you're going to do it in the inside at the tip?
Okay, Dr. Huang. Dr. Hanjin Park's question is power, duration, and contact
Okay.
inside the
So if you do the endocardial ablation, first, lucky for us that the appendage apical tips or very deep inside the appendage, it usually is not the focus. It usually is a half proximal in most of our cases. I have not seen anything in the apical tip. So if you have a wide enough room there, usually you can start with a 30 watts irrigation catheter easily without any problem. Contact sensor may help, may not, because of an appendage is mobile structure again. So I don't know how reliable I can trust that contact sensor. And the key is that you probably want to use if you're the beginner intracardiac echo, take a look at the appendage monitor. That's why I think appendage tachycardia, if you're going to do endocardially, single transeptal, I am not sure I feel comfortable doing that with a single transeptal. I like to have a double transeptal, one for imaging or one ablation catheter, one mapping catheter together. So keep the shape and the same and relatively immobile appendage so I can ablate with the 30 watts. Posterior wall with the junction with the appendage and pulmonary vein, you can ablate 35 watts without any problem. But again, you got to make sure that it doesn't go too deep into the body because you can make a steam pop in there. Because the blood flow in appendage is not as high as the region in the other area. Okay?
Okay, thank you. And let's move to the third case. Junyoung, please add the entrainment mapping and send it to me. All slide.
Case 3, I will present a very brief EGM review. This is a 58-year-old man with a significant medical history who presents with dyspnea of insertion, and the ECG showed arterial lockdown. So we proceed to EPS, and during the overdrive pasting in proximal CS, PKI cell was under GBO. So the ablation was successfully done. CTI ablation was successfully done. So we start the EP study after ablation with a single arterial extrastimuli. This is 600 and 310. You can see the histogram. And at 600, 300, we observed the infrahiscian block. There was a potential, but no subsequent ventricular activation. The same infrahiscian block recurred at 600, 290. And interestingly, conduction returned as 600, 280. Consistent with that phenomenon. At 600 to 70, this was the AB nodal ERP. So in this case, we can see this Purkinje block before AB node block and also get phenomenon. That's the end of presentation.
Impression block. Okay, but there was reconducted like a gap phenomena. Then next one, shorter coupling interval shows the nodal block, right? So Dr. Wang, do you see this kind of phenomenon often during the basic EPS? 스피커터 문제인가 보다. I'm sorry, that is our problem. 왜 그래? Can you hear me, Dr. Wang? I think you're on mute.
그 황준현 선생님 아까 잠깐 문 열고 지금 돌아오십니다. 잠깐 자리 비우셨었어요.
집에 가셨었어? Okay. Dr. Wang, can you hear me?
I can hear you.
Okay, thank you. So we saw the inflation block during the basic EP study. This patient has atrial flutter. After CT ablation, we did the basic EP study, and during single extra A stimulation, we saw the transient HB block, and his baseline HB interval looks a little longer than normal.
Right. Yes.
So how
What's
can
your
we explain this kind of phenomenon during?
Well, how do we explain this phenomenon?
Yes, and how should I explain to the patients?
Well, this is, first of all, is not a clinical consequences, right?
Mm-hmm.
Because of if you have his bundle infra-His block coupling S2 shorter than 350, is not a physiologic, is not a pathological problem.
Mm-hmm.
It's just simply a conduction safety issue. So this patient does not have any prognostic factor. Now, only thing worried though, I would say, look at the His bundle potential. You have only one channel recording here. This His bundle potential is normal, looks normal to you? That's the first thing I think we should talk about. His bundle potential. Why is it notched? Should do normally with his bundle notched like that? No. You see, in textbook what? Single potential, very sharp R wave, right? Unfortunately, you don't have any other channel recording, but then at least the proximal His does not have any His, but the distal has a beautiful His, but they are notched. Does that mean what? His conduction is abnormal. That's the first thing we need to say. What's the HV interval baseline? Was it normal? HV baseline, when you measure. HV, not that one, sinus. Next one. Yeah, that one you should measure. Is it normal or abnormal? You forgot to measure your HV, huh? I think it is long, Dr. Bob.
I think so.
Yeah, it is. This is a disease His bundle, okay? That's why it's so important you do all baseline study very carefully, able to provide the patient all the information you needed to. So this is not a normal His bundle. Patient has an underlying His bundle conduction disease. That's I can tell you.
But his AB block cyclensis was normal, and
yes, it is.
I didn't do anything to the His bundle, just ablated the CT, right?
Yeah, right. But what I'm trying to say, if we are doing study to the patient should be informed all the potential things that you find in the his study. That way, patient will be aware more potential future higher risk of a heart block and things like that. It's important for them. So that's why we all have to be collecting all the information during the study, not just ablating. Ablation is only one part of the equation we do. But a long-term prognosis of patient, things like that would be important data because you guys don't know what's the normal population, Korean population HB interval, do you? I mean, you're using all US data as Korean data. I disagree with that. I think ethnicity vary quite a bit. Okay. So this patient has, S2, as you've shown, AH, so does HB interval prolong a little bit. That's not normal. You don't see normal HB interval prolongation, do you? S1, S2? Do you see that? That mean, why the HB interval prolongation? Look at the His bundle HB duration versus S1 to S2. Look at the His bundle duration a little bit longer than S1. Yeah, it is. Okay. So all these things that you're telling you that this patient has intrahisian conduction disease, period. That's what the patient has.
Dr. Wang, so
Yes, sir.
last time we discussed about the triple His bundle potential.
Well, that's not his bundle potential. You're talking about Anderson's paper about the fragmented AV node business.
Because of our mapping catheter resolution is very low in this case. So some part of the His bundle potential, actually it was not the His bundle potential, but the fractionated potential around the AV node. So how can we explain the gap phenomenon after shortening the coupling interval of A extra?
As you know that His bundle conduction is His bundle per se, they have extremely sort of a well-organized fiber orientation with a rapid conduction speed. That I don't think His is, I'm aware, is that there's a gap phenomenon His per se. Suprahisian, there's a gap phenomenon, but I don't think His per se is known to have a gap phenomenon.
That's why my hypothesis that was not His.
This is not His, you're saying?
Right.
No, this is a His, my friend.
This is His. How do you know? 100%
Well,
sure?
because you have a very proximal far field. If you look at that potential, you have a very wide space catheter though, but still you should be able to see very sharp potential. But clearly, His when prolonged, AH interval prolonged, S1, S2. So it's got to be below the, AV node. Now, do you have a V conduction by any chance? S1, S from the V? May I answer your question? Ventricle.
We did.
You did? Let's take a look. Do you have a S1, S from the ventricle with a retrograde His? That's what I want to know.
그냥 했던데.
Patient has a VA block during the P pacing? Because, Purkinje network also can exhibit block.
VA dissociation.
VA dissociation. That may be because you probably has Purkinje myocardial junction block. Because the VA conduction can be delayed at the Purkinje level as well as the His bundle and then AV nodal, but predominantly AV nodal area.
But if it is a Purkinje junction block,
yes,
induce the gap phenomenon. The local V recorded his recording catheter V should be shown, but in this case, local V in His bundle recording catheter disappeared.
Wow, but if you look at your RV EGM, take a look at the RV EGM. Where you think you're pacing RV EGM? You're pacing the distal right bundle. But take a look at the sinus rhythm. Sinus.
Good.
Yeah, that's sharp potential.
Yeah.
Come back to the S1. S1 RV signal.
S1.
Keep coming back. Next one.
There's sharp potential.
Yeah, there is a small potential before.
Right.
It's the right bundle. You're pacing close the right bundle. So If you say that there's a VA dissociation, then patient has a probably distal conduction system block. That's what patient has. Because typically they would enhance the VA conduction here because you got small, low and noisy and then sharp potential. I think that's the distal right bundle branch you're pacing. I probably most pacing from the septum, I assume. And so I think, as far as the concern, you got a His bundle potential and then you got this is His bundle. That's what you got. Now, can you tell me something, Dr. Bob?
Yes.
Look at the QRS complex S1, S2. Why the different? QRS. Yeah. S1, S2 different. How do you explain that?
Yes.
If this is not a His bundle potential, you have to tell me that now.
That supports my hypothesis.
Oh,
I have
sure.
a
Yeah,
question
that's
about
wrong. That's I can tell you.
interstitial plug or the triple His bundle potential,
Yes.
or even though it's very extremely rare, there's possibility of another pathway, like a twin AP node.
Oh, sure, but it's not the case though, because your QRS changed with the HV prolongation. That means there's an interventricular conduction system problem here. So which is your His bundle partially, fibers are blocked same time. So that's why QRS changed.
Then do I have to explain to the patient he has a risk of heart block later?
Yes, you do.
Because he is an international lawyer working in.
It doesn't matter he's an international lawyer now. You just tell him that he should be monitoring.
Sue me.
I mean, you tell the patient the way it is, right?
Okay.
That's our job. Now,
second
question I have for you is that I know your catheter resolution is not high enough, but if you look at the local V and then His bundle timing wise, it's very short. You see that? In other words, S1 driving local septal A to the His bundle. Yeah. His distal. Go to His distal. You got A and B there. Almost there's no, HV here interval. Right? AH interval very short. HV is longer. So why is that? AH, almost no interval. They connect together. So if this patient has some sort of a fast pathway inserting into His bundle, what do you think?
Could be.
Could be, because the Sarosi paper, remember I sent you one time, sometimes they believe that the fast pathway, part of that inserts directly to the proximal common conduction system, which is His bundle. Therefore, those patients tended to have a short, PR sometime, or during the EP study, you have a short AH interval, like this one. So I think that this patient may have fast pathway conducting right through the proximal His bundle, small portion of AV node, but the HV is prolonged, I think, because His bundle disease. But I'm not sure this is a case of a triple His bundle potential or triple nodal potential. So we are discussing it because this patient PR is not short. Okay, that's like it so far.
Anyway, this area is still mysterious.
Yes, many interest. I'm still interested. Love to hear more about it, but I can't hear you now.
If you allow, I would like to share the paper you sent, review article you sent
Yes,
me.
please. Yeah, all the fellows should read it.
Okay, thank you.
Yeah, because this is indication.
Nice.
Yeah, because only people think about the embryology and then adult. Between that, what happened? Anderson paper explained nicely about that. What happened to the people growing up and teenage and all the neonate and so on. That give a better perspective of the patient care and the better EP guys. All four, please do that.
Thank you. It
All
is
right.
9:05 Saturday morning. Every young people want to go home and time. Thank you very much. I'm very happy to hear your voice again.
Oh, thank you so much. Had a wonderful conference. Great. Have a good time. Bye-bye.
Okay, bye.
Bye.
감사합니다.
감사합니다.
예.